For our EBP project, we looked at nurse education and pressure ulcer prevention.
Our clinical question was, does staff education on pressure ulcer and pressure ulcer risk reduce the amount of pressure ulcers in hospitalized patients? A therapy category is when a nurse wants to answer questions about the effectiveness of a particular treatment or intervention. Our study is looking at the effectiveness of staff education on the incident of pressure ulcers. The conceptual definition of pressure ulcers is a localized injury to the skin and/or underlying tissue, usually over bony prominence as a result of pressure or pressure in combination with shear. The conceptual definition of staff education is teaching of nursing, medical, and other members of the healthcare team process of assisting staff to gain knowledge, skills, values, and attitudes for maintaining and improving competences. Our PCOS statement is, for populations, hospitalized patients and healthcare staff; for interventions, pressure ulcer staff education; for compared, staff without pressure ulcer education; for outcome, it's pressure ulcers; and for time, it's while patients is admitted in hospital.
For searching, we use the CINAHL database. Our key terms were staff education and pressure ulcer. Without limits, we came up with 23 results, and then we added the limits of publication date within the last 10 years and the English language to come up with 16. So this is an overview of our studies. We chose 2 quasi-experimental designs, both with level 3 evidence. So one was a large and one was small sample size, but they were both pre-test, post-test, or the one group design, meaning that they collected data before the experiment and they collected data after the experiment. But there was no control group and no randomization. The 2 non-experimental designs were level 4 evidence, and that included a longitudinal study and a cross-sectional study.
My study is identifying gaps, barriers, and solutions in implementing pressure ulcer prevention programs. The purpose is to foster the professional development of expert nurse clinicians to become translators of evidence into practice. The population was from 4 hospitals, the pressure ulcer teams, and the design was non-experimental longitudinal. This fell into this category because it was non-experimental and done over a 1-year period where data was continuously gathered and analyzed. The methods used to collect data was a pressure ulcer prevention program inventory. Each participating hospital team completed the pressure ulcer prevention program inventory and provided prevalence and incident data regarding pressure ulcers. During the study, site visits occurred for a more in-depth analysis and support. In between site visits, a series of conference calls were held. There were 4 findings that were identified throughout the study: lack of physician involvement, limited involvement of unlicensed nursing staff, lack of plan of communicating at-risk status, limited quality improvement, evaluation of bedside practice. It was a large sample size for strength, and this was because the sample size was 4 hospitals, which include 4 different pressure ulcer teams, and this allowed for a greater generalizability to other hospitals and locations. Another strength was assessing change in variables over time, and this was done through first the inventory assessment at the beginning, and then 2 at-site conferences, and then phone conferences throughout the study. And limitation was that it was non-experimental, and because it was non-experimental, there was less evidence, there was no intervention group, and no control group. Therefore subjects were not randomized.
So my study was pressure ulcer knowledge, and the purpose was to examine Brazilian nurses' knowledge of pressure ulcer prevention, assessment, and staging. The population was done through a convenience sample with 106 BSNs from a university hospital in Brazil ranging from 25 to 58 years of age. The study was a cross-sectional design in which they adapted a pressure ulcer knowledge test known as the PUKT test, where questions were added to fit Brazilian healthcare system or taken out. The first section assessed information on demographics and education of the nurses, and then the second section was a questionnaire that consisted of 47 questions to assess pressure ulcer knowledge, with answers being true, false, or don't know. The results of this section were then analyzed via the Pearson correlation test. Finally, the researchers looked at the relationship between the scores and each nurse's experience on floors. So the findings of the test were that the least known information was about minimizing pressure ulcers, friction, and shear force, and that years of experience were negatively correlated with scores by 21%. There's also only 42% of questions that were answered correctly by 90% or more of the nurses in the study, and the nurses that answered the most questions right were in direct care. So the limitations of my study were that it was a small sample size and only from one hospital in Brazil, which decreased the likelihood of the study to be generalized. Also, you can't establish an interrelationship of the phenomenon because there were no control group and trial group or intervention, so you don't know what exactly controlled the outcome of the situation. And the information was also superficial because it was only done from surveys. So the strengths were there was phase and content validity because the test measured what it was intended to measure, and it measured all facets of pressure ulcers, being assessment, prevention, and staging. It also had inter-rater reliability because the data was analyzed using SPSS 17.0 software, the Pearson correlation test, descriptive statistics, and a t-test where all variables were considered statistically significant if the p-value was greater than 0.05.
My article was decreasing the incidence of heel pressure ulcers in a long-term care by increasing awareness, so it was a one-year program. So the purpose of the study was to determine the effectiveness of staff education awareness on pressure ulcers, on the incidence of pressure ulcers, as well as daily heel assessments and heel pressure relieving measures on the incidence of pressure ulcers. So the population was 40 residents in a long-term care facility, 19 men and 21 women with a mean age of 67 years old. So the unit was randomly selected from the facility, but the residents themselves were not randomly selected. So the research design was a quasi-experimental one-group design, and this is because there was no control group and no randomization of the participants, and data was collected before the experimental treatment and after the experimental treatment. So the measurements used was the Braden scale and the heel assessment form. So the Braden scale was used to obtain the status of current pressure ulcers and the risk status that someone may develop a pressure ulcer before the experiment began, and then again it was used at the end of the experiment to see what was there. And then the heel assessment form was developed by a certified wound and ostomy care nurse. So it had lots of different categories that the nurses on the floor could use every day to mark what they see on each patient's heel. So they were able to mark whether the heel was boggy, black, bluish, purplish, cold or warm temperature, and whether there was arrhythmia present. So the findings showed that there was a prevalence rate of pressure ulcers at the beginning of the study of 22.5%, and then at the end of the study when they looked back at the pressure ulcers, there were none. So, and then the percentage of residents at risk at the beginning remained fairly similar to the residents at risk at the end. So it indeed does confirm that increased caregiver awareness and education and different assessments help reduce the incidence of heel pressure ulcers. The strengths of this research was that it was practical and feasible, so it was easily integrated into the nurse's daily routine and there weren't a lot of monetary constraints. The review of the literature was consistent with the findings that staff education decreases the rate of pressure ulcers. There were standardized interventions, so all the staff had the same education and they all used the Braden scale and heel assessment forms the same. And they also would put up pictures of different stages of pressure ulcers around the unit, so that way the healthcare workers would be more aware. And they all used these kite symbols on every patient's bed that had a pressure ulcer to designate to the healthcare worker that this patient had a pressure ulcer and what stage it was at, so every patient had that had a pressure ulcer. There was homogeneity between residents, so they all were in the healthcare facility for similar reasons. So that is a strength in that aspect for the study, but it means it also can be a limitation because it limits generalizability to different people not in long-term care. So some more limitations are staff compliance to intervention, so only 79% of the nurses completed the daily heel assessment forms. It was a small sample size and convenient sampling, so that limits generalizability. There was mortality, so some of the participants were deceased during the time of the study, or they were transferred or discharged from the facility. And mortality is a threat to internal validity. And then without the random selection of participants, that was a threat to generalizability. There was no control group, so there was nothing to compare the results to, and they only looked at heel pressure ulcers.
The study was designed to examine the effects of an intervention on discharge destination, function, length of stay, pressure ulcers, and fall rate in older adults. My population was 404 patients with the mean average of 84, all over the age of 75. The design was quasi-experimental pre-post test with 2 phases. The first phase being a workshop for staff, CNAs, standardizing care for the patients, and the second phase was infrastructural change over 2 months and data collection over 9 months. The level of evidence was 3, and the findings in the workshop, the CNAs standard the care for the patients by getting patients out of bed for all meals, ambulation in the hallways 3 times a day if patients were able, repositioning bedbound patients, CNA reporting of change of shift, documentation of frequent repositioning and hallway ambulation, and report between registered nurses and CNAs to build accountability. Most importantly, the new infrastructure standardized patient care across the nursing staff. The findings were staff education significantly decreased nosocomial pressure ulcer prevalence from 10.7 to 5.9. Providing quality care for the hospitalized elderly requires not only knowledgeable staff, but infrastructure that supports the transfer of knowledgeable practice. The strengths of my experiment were a large sample size, homogeneity of the sample, standardized care practice, and more CNA involvement. The limitations of my study were staff members not adhering to the intervention protocol, lack of comparison unit to serve as a control, and patient selection.
We had basically 2 quasi-experimental studies and 2 non-experimental studies, where the 2 quasi-experimentals looked at the effects of staff education and pressure ulcer incidence, and they looked at both nurses and the patients, where the 2 non-experimental looked at just staff education and the knowledge of pressure ulcers. Our measurements, we were all standardized, where the 2 quasi-experimental designs used the Braden scale, and the 2 non-experimental designs, one used a questionnaire and scale and the other used an educational program. For findings, in all of our studies, we found that staff education is very important to decrease the risk of nosocomial pressure ulcer incidence in the hospital. So our recommendation is that staff should be educated because that decreases the incidence of pressure ulcers, and that we need more studies done with a higher level of evidence, such as randomized controlled trials, to improve this certainty. Our level of certainty regarding the net benefit is moderate because the findings were consistent. However, there is limited generalizability because some studies had a small sample size and not a lot of research articles were found, as well as there weren't as high evidence as we could have had because the only studies found were level 3 and 4. Our recommendation is grade is a B because there's moderate certainty that the net benefit is moderate to substantial.
The implications for professional nursing practice would be to make use of the Braden scale to assess patients after every shift, as well as communicate findings with oncoming nurses. Staff members need to be accountable for their actions and adhere, as well as continuing education programs for staff members. A system of ensuring healthcare compliance would financially reduce length of stay as also reduce stress on patients and healthcare workers. Future research questions could be, do patients who are taken care of by nurses that educate and follow strict rules on checking patients every shift have less pressure ulcers than those who are taken care of by nurses that do not go through ongoing education? Another question could be, do patients that are educated by nurses at the bedside have less pressure ulcer incidents? We look forward to your questions to come.